who was being followed up for pneumonia and basically unrelated issues. And we did note that there was a plaque of calcification, and his aorta, according to his age, is kind of slightly dilated, tortuous. In the subsequent X-ray, which was done as a follow-up of his illness, which was not related to aorta, demonstrated that there is now a bulge in the aorta. And if you visualize that the intimal plaque or the calcified plaque has moved inside, and this is what his CT looked like. So he had developed in between these two X-rays a large, basically a contained rupture of his aorta. So X-ray, if looked at carefully, can sometimes be helpful, though it is not the sole modality on which anybody would rely. TEE is not my specialty, but I will quickly go over that. The most important thing is that when the patient is crashing and you cannot take them to the CT suite, at that time TEE comes very handy because it can be done right on the operating table, and then real-time imaging can be obtained. And this is an example given to me by one of my cardiologists, where we had done this CT because this gal was diabetic, and so we could not give her contrast. So she had come with some pain in her back of her chest, and people were actually thinking about more of a thoracic spinal cause for her pain. But lo and behold, we found that her aorta, her descending thoracic aorta, as you can see, is dilated, and you can also see a dissection flap on the non-contrast CT. So I emphasize that even if you have a non-contrast CT, do not just blow it off. Just take a good look at it. Sometimes you may find something over there. And then there is hemothorax in the pericardial, in the pleural space. And this was the TEE, which was performed on this patient, which demonstrates the true lumen demonstrating the blood. And this is the thrombosed false lumen. And that, of course, is the effusion that we saw on the CT very well. This is a rather busy slide, so I will head on to the next one, where we will talk about the diagnostic modalities a little more. MDCT has now come to be the gold standard for acute aortic syndrome with almost 100% sensitivity. TEE is, as I said, is also highly sensitive, but it can also give dynamic information. MR is not practical because of time constraints. MR takes a much longer time, and we probably do not have that much time in an acute aortic syndrome setting. I will not emphasize much on the technique in this scenario, but if anybody wants to ask me questions about that, I will be happy to. The only thing I will emphasize is the reconstruction of the aorta is very important. So what we rely a lot on when we're making a diagnosis is the left anterior oblique sagittal reconstruction, which gives us this candy cane aorta appearance, which is very helpful not only for the radiologist, but for the cardiothoracic surgeon who can visualize the things in his own perspective. And here is, this is a standard in my institution, that if we have a patient where we are suspecting aortic dissection, we always gate the study. And now the question is, why should we gate the study? So like, as in this patient, this was a patient of known Marfan syndrome, and we see that this is the region of the aortic root demonstrating these linear lucencies. So one begins to wonder, this patient is very likely to get aortic dissection, and their aortic root is a little bit dilated. Have they developed an aortic dissection or not? So we had to clarify that by gating. So we imaged the aorta in such a way in one part of the cardiac cycle so that we can omit the cardiac motion. So as you can see, this patient did not have any aortic dissection. So just a quick reminder to everybody about what are the normals for the aorta. This varies from institution to institution, but what we follow is that the root and the ascending aorta should be 4 cm, and the descending and the arch should be 3 cm, and the abdominal 2 cm. And this again depends upon the comfort level of the cardiothoracic surgeon. And in my hospital, at 4.5 cm, we start 6 monthly surveillance, and at 5 centimeter of aorta at any point in time, we go for the surgery. This is a very basic slide talking about the 3 layers of the aorta, and I brought this to kind of in a prelude to the pathogenesis of the aortic dissection. So basically, aortic dissection is a process which starts as a tear in the intima with the blood leaking into the medial space, and then there is usually an exit tear that forms. And so there is blood in the wall of the aorta, or more specifically in the media of the aorta, which leads to formation of a true and a false lumen. The basic classification, which everybody is very aware of. So basically, when the ascending aorta is involved, it is type A, and when it is descending thoracic aorta beyond the the right subclavian, then it is called the type 2 or the type B dissection, and then we follow the Stanford system. How can a radiologist help? So there are some very important questions that we can answer, and if we answer them in a timely fashion, we can be very instrumental in saving the life of the patient. First of all, talking about what type of dissection is it, and I will proceed to the next slide to show you some of these examples. So Stanford type A dissection is the most common type of aortic dissection, and the important part is that if it remains untreated, then it can lead to very, very significant numbers of mortality. So it can lead to about 38 to 55% of mortality in 24 hours, which has been said in various series, and about 50 to 60% in 48 hours. So it needs to be identified immediately. This is an example of type A aortic dissection. This is the aortic root. This is a coronal reconstruction, which is demonstrating that the aortic root is dilated, and this is the dissection flap, which is also extending into the branch vessels. And this is the usual axial image that we are used to seeing. And the type B dissection, as I said, is the lesser common form, and it usually takes the medical treatment as its intervention. However, sometimes we need to do a surgical intervention, and we have special situations for that. We will talk about that shortly. The type B dissection, this is an example. So this is the ascending aorta, and this is the descending thoracic aorta, which is slightly dilated. And it is demonstrating that this is the true lumen and this is the false lumen. And as you can see on the reconstruction, this is the left subclavian artery taking off and the dissection starting right after that. Now, the extent of the aortic dissection, we can give very clear information about the proximal and the distal extent of the aortic dissection, which comes in very handy to our surgeons. As in this case, we are demonstrating that all the three branches of the arch of the aorta are involved with the dissection flap, and in that case, we often go up in our imaging to see the caudal extent of this dissection flap, or if it is getting into the carotids, we can use Doppler for evaluation. And this is demonstrating the distal extent of the aortic dissection in the descending thoracic aorta. As you can see, this is the bifurcation. True and false lumen. Now, this is an important part of the evaluation to be able to determine. So usually, for what I find most reliable is that I follow the left ventricular outflow tract on my axial images, and whatever lumen continues is the true lumen. However, there are other ancillary things that you can look for. The smaller lumen is the true lumen usually. As you can see over here, it has been reduced to a small concavity. And usually it is the more opacified lumen because that is directly communicating with the left ventricular outflow tract. Often it has been seen to be located anteriorly, although that is not the rule. And most of the times it gives rise to the coronary arteries, which is very important for us to be evaluating as well. This is an example of type B aortic dissection demonstrating the true and false lumens, as you can see. And then the false lumen, as you can see, is is the larger lumen, and it is more prone to thrombosis, and this is the lumen which usually enlarges, leads to aortic rupture. So it's a good idea to keep an eye on the false lumen, especially in type B aortic dissections if we are following up the patient. The false lumen, one of the very specific signs of being able to detect false lumen is to be able to see cobwebs. Now, what are cobwebs? These are residual fragments of the aortic media that were separated during the dissection. Why do we need to figure out which is the true and the false lumen is? Because now we do a lot of endovascular repair rather than open heart surgery, and we definitely do not want to put the graft in the false lumen. We want it in the true lumen, and we want to save the origin of the vessels. And this is a special type of dissection where there is a 360-degree tear of the intima, which leads to a basically double barrel kind of aorta. As you can see, this is the true lumen, and this is surrounded by the false lumen. This is yet another example showing the circumferential tear of the intima and demonstrating the true lumen inside, which is the darker lumen, and the false lumen outside. There is a problem in this sort of dissection that it can lead to branch vessel obstruction, so should be recognized and treated appropriately. Just a quick word about the complications. This is a entity which involves high mortality, so have to be very careful. Acute aortic regurgitation can occur, which is mostly evaluated with echocardiography, but we can be helpful in other situations, like as in this case, we see that this is the ascending aorta, and we see this crescentic hyperdensity, which is an intramural hematoma, and this is there is some pericardial effusion, which was high density, and hence it was hemopericardium. This patient was taken to the OR and in a timely manner. And this is another very nice example where this was given to me by one of my friends, where you can see this hyperdensity which is extending into the pulmonary artery. So basically, this is the hematoma which has extended into the adventitia of the pulmonary artery, and as you can see, it is being compressed, and you can see the hemopericardium. This entity does not have a very good prognosis. This is involvement of the branch vessels by the aortic dissection, the celiac, the renal, right renal, and into both the common iliacs. Now, signs of potential perfusion deficit, which is very important because that determines that how quickly we should intervene and where we should intervene. So, as you can see over here, that the dynamic branch compromise have been sometimes observed on the TEE, which we cannot image. And this is an example of a renal infarct secondary to aortic dissection, and over here we lost all the perfusion of the kidney secondary to the aortic dissection. So these ancillary information is very important. The treatment of type A is mostly surgical, as you know, and the descending thoracic aorta can be managed with medical management. However, if the patient is having persistent or recurrent pain, expansion of the aorta or expansion of the false lumen, or there is progression of the aortic dissection or end organ malperfusion, then in those situations the intervention has to be performed. An example of a stent graft placement in a, this is basically this was started off as aortic dissection and then ruptured a contained rupture happened, and then aortic stent graft was placed. This is an example of open surgical repair. So here, this was his pre-surgical image. So this is one graft and this is the other graft, and as you can see on the reconstruction very well, this is a Dacron graft which has been replacing the ascending aorta. Now, surveillance, I will not get into that, but this is also a beautiful case where we did a endovascular repair and there was leakage of contrast outside. So this was a endo leak which was happening from a subclavian artery, and this patient died about 6 hours after this study because she was having a maximum.
Now, you could perhaps summarize your talk, please.
Oh, sure. So I will quickly go over the pitfalls that we have to be aware of artifacts and things like hemopericardium or the pericardial recess mimicking aortic dissection or the compressed lung. And I will, this is Dr. Deepak, the one who designed the surgical treatment for, he's himself got aortic dissection 3 years back. This is an example of intramural hematoma where there is high density blood in the wall of the aorta, and this is treated pretty much like aortic dissection. And quickly I will go into the penetrating aortic ulcer, an example of penetrating aortic ulcer where there is a break in the wall and there is a contained leak. This is another nice example of penetrating ulcer which was treated with endovascular repair. And this is, since I'm running out of time, but I can share this talk with anybody who wants to. This is a large aortic aneurysm, and since it is, it was demonstrating the size of MDCT and TEE are the basic 2 modalities which are used for evaluation for acute aortic syndrome. MR for very special situations like contrast allergy, but usually not done. And imaging appearance is imperative. Mimics are very important to recognize because you can't, you definitely don't want to take anybody not having aortic dissection to the OR. And the optimal imaging technique is required. Well, thank you very much.
Thank you, Archana. That was...
It was a very good presentation. And regarding that point you made, we got a referral from a hospital referred as a patient of acute aortic dissection and with a CT, but somehow the presentation was not fitting in. So we again did a CT scan at our hospital, which was gated. And then that ruled out that there was no dissection. And it was in the middle of the night. It was a dilemma for the family because they were told that you need an urgent emergency surgery and then they came, and then we got it done, and then it was ruled out that the patient did not have aortic dissection. Thanks a lot.
Yeah, that's an excellent point that you've made. We encountered such situations, and in fact, unfortunately, we have one case where the patient was taken to the OR and nothing was found. But luckily for the patient, they did TEE prior to the surgery, so we were able to figure that out, that there was no aortic dissection. So that is why in our hospital, we have, because we are trying to balance the radiation dose, so we have omitted the pre-contrast CT, and we now do gated cardiac CT for every patient who has suspected aortic dissection. In fact, we try to do a kind of an altered triple rule out for every patient who comes with acute chest pain. And basis of that was pretty much your scenario. So, and that's what we have resolved to. And now we have tried, in a couple of cases, dual energy CT, where we have been able to generate pre-contrast images from the direct contrast CT, which is very useful.
Any suggestion regarding, like, if an elderly patient, do you screen for the coronary artery disease also if the patient is having dissection? How do you do it?
Yeah, that's right. Because basically, you know, now the trend of radiology or trend of medicine is going towards triple rule out. So when we do have to do a investigation, we do investigate the coronary arteries. And since we our scanner, we have a dual energy scanner, so we try to accommodate all our aortic dissection or acute chest pain patients on the dual energy scanner, so that we can get our scan in a very short time, including getting, it's a standard with us to go down to the level of aortic bifurcation, and we reconstruct our data as much as possible for at least the proximal coronary arteries. Sometimes we will not get good distal coronaries, but definitely for the proximal 2/3 of the coronaries.
Thank you.
Yes, I think that's the standard approach nowadays. Okay. I think we've had an excellent lecture from Archana. And we move on to the, thank you Archana once again. And
Thanks,
we move
ma'am.
on to the next speaker.
Thank you, everyone.